being here today. Our topic is health equity. And so I'm going to talk about what makes us healthy, that's the health part, and how those things that make us healthy are distributed in our community. That's the equity part. So this is Daisy. Now, Daisy is a professional woman with 2 kids who lives in Franklin County. She lives here in this Pioneer Valley, and she listens to New England Public Radio. When she turns on the radio and tunes into the political discourse, what she hears about most often is health care. You know how it goes: pre-existing conditions, individual mandates, high-risk pools, and so on. Now, Daisy has good, affordable health care, her insurance that she gets through her employer. She gets the clinical care she needs when she's sick and the preventive care she needs when she's not. While her own costs are manageable, she sees her premiums going up every year, and she's aware that as a nation we spend a lot on health care. We can't come to agreement about how to contain costs. So let's take a look at that spending. This chart shows U.S. spending on health care as a percentage of gross domestic product compared to other wealthy industrialized nations. And so there we are on the top, represented by that black line. So in 2013, we devoted about 50% more of our GDP to health care than did these other countries: France, England, Japan, and so on. I'm sure it won't be news to you that we don't get 50% more good health for our spending. Let's take a look at what we do get. Life expectancy is often used as an indicator of society's overall health, and this chart shows life expectancy at birth for OECD countries, that's Organization for Economic Cooperation and Development. These are 35 democracies with market economies. So Japan has the highest life expectancy at 83.7. The average life expectancy for OECD countries is 80.6. And here's the US, below average at 78.8. Here's another way of looking at it. So along the x-axis of this chart, we have spending on health care per capita, and you see that the US is an outlier out there on the right, well to the right of the other countries. Life expectancy is shown on the y-axis, and as we saw before, many countries have longer life expectancy than we do. And so if you draw a line along here, you see that in life expectancy, the US is about on a par with the Czech Republic or Chile, which spend less than a fourth of what we spend on health care. So I'm sure there's several lessons we could take for this, and I'll mention 2. First, as important as health care doesn't make us healthy. It's often what we use most often after we're already sick. So health is more than health care. Second, the life expectancy shown on these charts is average life expectancy, and good health, like income, is not evenly distributed among our citizens. Among peer countries, the US ranks high in income inequality and low in health. Inequality, economic and political, is bad for our health. Now, in the field of public health, typically we talk about not health inequality, but health inequity, meaning it's not just that there are differences, but that the differences are systemic, they're avoidable, and they're unjust. So if healthcare isn't making us healthy, what is? And how are these things distributed in our communities? To break it down, I'm going to use the Robert Wood Johnson's County Health Rankings model. So the Robert Wood Johnson Foundation uses this model to accumulate data from many sources and assess the health of every county and every state across the United States. Are you familiar with the County Health Rankings model? If you're not, I suggest that you Google County Health Rankings and see where your county stands compared to others. So according to the Robert Wood Johnson model, healthcare accounts for 20% of our health status. Now you'll remember that Daisy has good health insurance and access to the care she needs. So for her, the doctor is in. She has that 20% covered. What else is there? Well, one thing that leaps to mind is food. We are acutely aware that what we put into our bodies affects our health, and we're obsessed with the latest diet news. Despite our obsession, however, our waistlines continue to grow. So let's again compare ourselves to peer countries, this time in obesity among adults. Japan is best. It does best at 3.7% of its adult population obese. The OECD average is 19%, and here's the US at 35.3%, almost 10 times greater than Japan. And this fact has an impact on the overall health of our society. So according to the Robert Wood Johnson model, health behaviors like diets and exercise, tobacco, alcohol, and drug use make up 30% of what contributes to our health. Now, Daisy gets her exercise, as you see here. She has a healthy diet. She doesn't smoke or use drugs, and she drinks moderately. She practices safe sex. So she makes smart choices. We'll come back to the idea of smart choices in a bit. But for now, we see that Daisy is doing very well so far. She has this 50% of the model working in her favor. But we're still missing half the model. So what else is there? Robert Wood Johnson attributes 10% of our health to environmental factors, namely housing, transit, and air and water quality. Now, Daisy lives in this nice house. Its electrical system is up to code. The plumbing works, and the water coming out of her taps is clean. There's no lead paint flaking off of her windowsills or mold or contaminants giving her children asthma. When she goes outside, as you can see, it's green and lovely. There are no nearby factories or highways sending pollutants in her direction. Daisy has a car, which opens a world of opportunity to her in this rural valley. Opportunity in work, recreation, socializing, and doing the things that help keep her healthy, like shopping at any of the 3 large grocery stores or organic food co-op nearby. So things are looking good for Daisy for 60% of the model. We've got 40% left. This, the biggest slice of the pie, goes to social and economic factors, including education, employment, income, family and social support, and community safety. Daisy has a college degree. As a matter of fact, both her parents went to college, and Daisy grew up knowing that she would go to college too. Daisy's children don't doubt that they're college-bound as well. Daisy has a stable job with a steady paycheck at a workplace that's family-friendly with vacation, sick leave, and a retirement plan. She has family and friends who have resources who can help her out if she gets in a tough spot. She lives in a safe neighborhood with neighbors who have known each other for years and who look out for one another. She doesn't worry about her kids' safety when they play outside. So Daisy has the whole pie. And these factors, the 50% on the left, are what we call social determinants of health. They are what enable Daisy to have the 50% on the right. They make it possible for her to access the health care she needs and to maintain a healthy lifestyle. The Robert Wood Johnson model reminds us that the choices we make are shaped by the choices we have. So in America, we tend to see these smart choices as the key to good health, and poor health as the result of poor choices. We're individualists to the core, and we like to see ourselves as masters of our own fate. That's one of our strengths. But the flip side of that strength is that we naturally focus on the health behavior slice of the pie and blame those whose choices aren't optimal. And we lose sight of the full spectrum of factors that shape people's lives. So let's look at the left side of the model to see how environmental and socioeconomic factors are tied to health. So here is a map showing poverty rate by state, with deeper colors indicating a higher percentage of the population living in poverty. Compare that to this map of life expectancy, with deeper colors indicating lower life expectancy. So there's a striking overlap between the two maps. Note, for example, the cluster of darkly colored states in the South with high poverty rates and low life expectancy. Economic disparities shape not only what kind of car we drive, or if we have a car, or whether or where we vacation, but how long we get to live. The life expectancy gap between U.S. counties is growing and now spans 20 years, from 87 years in wealthy places like Marin County, California, to 67 years in high poverty areas, and the lowest is home to a Native American reservation in South Dakota. That's the same as the difference in life expectancy between Switzerland and Rwanda, all right here in the United States. I bet you're also noticing that the correlation isn't perfect. So look, for example, at California. It has higher life expectancy than you would think, given the percent of people in poverty. Same thing for New York and Massachusetts. So maybe we may be doing something positive in Massachusetts to ameliorate the effects of poverty. Towards the end of the presentation, I'll come back to that point briefly. Now, these maps emphasize the extremes, but what we have in America is not just a gap between the rich and powerful and the poor and disempowered. We have what we call a social gradient of health. On this chart, the x-axis shows income percentile from 1st percentile to 99th, and the y-axis shows expected age of death at age 40. So every step up the income ladder buys you a little more health, a little longer life. Health is also strongly correlated with education. This chart shows self-report of health status by education. So the Centers for Disease Control surveys Americans, and among other things asks, would you say your health in general is excellent, very good, good, fair, or poor? And people with a college degree are about 2.5 times as likely to say that their health is very good or excellent as those who didn't graduate from high school. So we see how strongly health is tied to the distribution of resources. The single strongest predictor of our health is socioeconomic status, whether measured by income, education, or occupation. Those at the top have the most power and resources and live longer than those at the bottom. Now, Daisy has another thing contributing to our good health that we haven't mentioned yet. What else can we say about her? Say, as compared to her colleague Jasmine? Yes, Daisy is white, and in America, that fact confers an advantage in health outcomes. The gap between races shows up for many measures of disease and disability. It's particularly stark for a key indicator of the health of a society, infant mortality. So this chart shows that African American babies are more than twice as likely as white babies to die before their first birthday. Of course, race in America is correlated with socioeconomic status, and indeed, these two factors work together to create health gaps between black and white, as we see on this map of Washington, D.C. So deeper colors show higher infant mortality rates and lighter colors lower rates. So here, in one of the lighter sections of the map, is Ward 3, with a population that is 6% African American, with an average family income of about $250,000, and the infant mortality rate is 1.3 per 1,000. Now go across town to Ward 8, which is 94% African American, with an average family income of about $45,000, and an infant mortality rate of 12.5 to 1,000. So that's 1.3 versus 12.5, all within one city. So socioeconomic status and race are entwined, but differences by race persist, even after controlling for income and education. So, for example, studies have shown that black women who receive prenatal care starting in their first trimester are more likely to lose children than white women who never see a doctor during their pregnancies. Black women with advanced degrees, doctors, lawyers, MBAs, are more likely to lose infants than white women who haven't graduated from high school. We can control for socioeconomic status and see what residual differences can be attributed to race alone. So, for example, here we see that at each education level, black men and women have higher heart disease rates than whites. So how can this be? All human beings, whatever their race, share the same set of genes. Now, incidentally, Daisy took one of those mail-order DNA tests and found out that genetically she is more similar to her black colleague, Jasmine, than she is to her white neighbor, who looks a lot like her. Increasingly, researchers are looking not at race per se as the extra factor to explain these residual differences, but at racism, discrimination, segregation, and social exclusion. Racism imposes an added health burden. The impact on health of racism on health is largely attributable to chronic stress, because chronic stress can be toxic. With chronic stress, the body's fight or flight systems get stuck in the on position with serious long-term health consequences. One major study demonstrating the connection between chronic stress and poor health is the ACE study, the Adverse Childhood Experiences study. Are you familiar with this? So the ACE study showed that when children are exposed to traumatic stress, their health suffers, and not just in childhood, but into adulthood, with increased risk of cancer, heart attack, stroke, depression, addiction, and early death. So we may forget incidents or block them from our memories, but our bodies don't forget. Our bodies carry the stories of our lives. The people who are subject to chronic stress are those who are exposed to high-demand situations where they have little control. So we tend to think of the CEO of a company as the one who's under greater stress than the line worker. But the CEO has the power and resources to manage those stressors. Further down the ladder, the stresses accumulate, like insecure jobs, substandard housing, unreliable transportation, and so on. The ability to control stressful situations decreases. Racism acts as an additional stressor, and it's not just the big, obvious forms of racism, the young black men killed and incarcerated, or the white supremacist rallies, but it's the daily slights and suspicions and fears. These stressors wear and tear on the bodies of people of color. They raise heart rates, blood pressure, cortisol levels, and undermine health over time. So now what? What do we do about health inequity in America? We can start with the recognition that health inequalities are not natural. It's not our genes that are primary drivers of our health, but social, economic, and environmental forces. And these are things that can be influenced by policy. The inequity we observe is a result of policy choices we have made. We can look to other countries that have longer life expectancy than we do for ideas about what to do. When we broaden our view of spending on health and consider social spending that supports health, like rent subsidies, employment training, and family support, we're no longer the biggest spenders. We spend more on health care, that's the light blue, and you can see us in the middle with the highest light blue in this chart, and less on social programs, that's the dark blue. Again, we have the smallest piece of dark blue there on that chart. These other countries invest more in social services and income equity and achieve better health outcomes. They show us that social policy is health policy. Here are some things communities can do to promote health. And these things are associated with socioeconomic factors. They're not totally contingent on prosperity. So remember, we saw that the life expectancy in Massachusetts was higher than you might expect, given the poverty rate. That might be achieved through investment in these things. You want to improve population health? Invest in education. Let's go back to where we started, healthcare spending. When we fail to invest in the conditions that can improve health, this is what we get. We end up paying more for medical care to treat excess illness. When we fail to invest in the conditions that can improve health, we lose the talents and energies of our fellow citizens. We lose productivity and economic growth, and we all pay the price for poor health. So that's the end of my presentation today. And if you would like to learn more about health equity, I suggest you go to this website. You can find it by Googling Unnatural Causes. Unnatural Causes is a documentary film series on health equity. And the website supplements the video with articles and educational materials, including a handout of 10 things to know about health, which are the very 10 things that I emphasized in this presentation.
All of our productions at GCTV are sponsored in part by Bay State Health, providing the care you and your family need when you need it close to home. Visit them online at baystatehealth.org. Greenfield Savings Bank. Visit them at 400 Main Street in Greenfield. Call them at 774-3191 or go online to greenfieldsavings.com. Greenfield Community College, providing access and excellence in higher education in the Pioneer Valley. Visit them at gcc.mass.edu. The Hammond Family. The Hammond family are longtime supporters of Greenfield Community Television. New Fortune Chinese Restaurant on the Mohawk Trail in Greenfield. Visit them online at newfortunema.com. Call them at 772-0838 and check them out on Facebook. Real Cleaning Services, cleaning Hampshire and Franklin County since 1972. We don't cut corners, we clean them. Check them out online at realclean.com. Call them at 413-422-1143. People's United Bank, located at 45 Federal Street in Greenfield. You can call them at 774-3713 or visit them online at peoples.com. The Solar Store of Greenfield, replacing fossil fuels and nuclear power one home at a time. Visit them at 23 Fisk Ave. Call them at 413-772-3122 or visit them online at solarstoreofgreenfield.com. Thank you to our sponsors for supporting all of GCTV's productions.